going to kickstart the questions, Ravi, and with the genetic side of things.
Yes, please.
So here we are in 2024, and you make a diagnosis on scan of tetralogy of Fallot, let's say, or you make a diagnosis of, well, let's start with, say, conotruncal abnormality. The rest of the baby structurally looks normal. As you say, Rabbi, how do you know when it's isolated? But let's say the scan's done by you, Rabbi, so it's isolated.
Not even me.
Okay. So you have an isolated abnormality, and you are at 20 weeks of gestation. I'll start with 20 weeks, then I'll go back to 13. Okay. You're at 20 weeks of gestation. I want you to give me an overview of where we stand with regard to your thoughts on genetic associations and the process by which you go about amniocentesis and what tests you run in terms of starting off with fish, 5-probe or 6-probe fish from banded karyotype to chromosomal microarray to exome sequencing, where we are today and where you think it's going in the future.
Well, this is quite easy question, actually, but the answer...
Easy for you.
No, but I mean, it's a straightforward question because it's could be every day occurring, nothing special at all. But let's say what we should also emphasize all the time is genetic examination like exome is evolving and the price is going down. We used to spend earlier for Sanger sequencing some 4 weeks. Today, they are finishing the exome examination within 2 weeks and sometimes easier than doing the karyotype. So the problem in all our discussions is some tell me in our society it's not covered by the insurance company. In this society it's covered and so on. Because if this is the basic of discussion, it's not scientifically. From scientific point of view, you should today do exome, period. Because in 5 years from now, people say, okay, we are doing exome. I remember there was times that, do you really perform macroarray on every fetus today? So you ask, why are you not doing this anymore? So this is why the answer should be independent on insurance coverages. What would be the best approach? The best approach for our geneticists is we do for next day the fish plus 22q11, and they start after that running the exome, the trio exome. So this is because then if you have an Alagille syndrome, you may discover this in 10 days after the examination. If you do microarray, you wait 2 weeks and it is normal. You run after that additional 2 weeks. You have 4 weeks waiting until the result.
But Rabbi, that's, I mean, when you're running 2 tests in parallel, I mean, there's the whole additional expense of running 2 tests in parallel, no?
But you know, cardiac surgery is not cheap, neither.
Okay. Yeah, because I mean, it's a debate.
One day on the intensive care, 2 days intensive care unit is already, let's say, exome plus extras. So. You know, if you tell the parents, and either you can afford to pay this amount of money, or you have a lifelong baby with, let's say, problems, they may discuss with you. And some, let's say, in some situations, they may come and say, you know, I'm not really daring to have a child with tetralogy because I may consider termination pregnancy. I said, no, please give it a chance. If it's isolated, the chances are excellent. So, and then we go for isolated. And how can you exclude isolation? We tell them this is the maximum we'll do. I'm sure, I bet with you, in 3 years we'll be sitting here and you'll ask me, Rabbi, are you still doing exome? Why are you doing genome sequencing?
Yes.
Because it's quicker, cheaper, you are finishing within 5 days. And why are we still doing exome? I will tell you, because the insurance company is not paying for exome. This is because, this is quite developing.
And I think, I mean, I'm looking forward to Jelani and Bev's take on this in terms of a postnatal point of view. So we'll probably come back to that in a second. Fanula, the Irish context in terms of diagnosis of major congenital heart defects and what's the state of play in terms of genetic investigations process?
We have good antenatal detection. I think it's around 50%, which is similar to other international centres in terms of antenatal detection of congenital defects. We do have a paucity of geneticists in this country, so we've a very small number, but we do have a perinatal geneticist based in National Maternity Hospital. So we would do karyotype microarray, and then, depending on the result and other scan findings, then to go on to exome, but it would be something we would do as a second stage. And I suppose one of the issues that we find, of course, is if we do find genetic results that we're not sure what they mean, there, extensive counselling is needed, and the implications for parents and family and so on. So I think the genetic testing should be done in the setting of, a robust and supported genetic service.
I mean, I think that's a very key point in a sense, and it's a very relevant one in Australia. Firstly, it's the late diagnosis, because by the time we don't have the luxury, in a sense, what Ravi has with exome sequencing as a first-line option. We do the amnio, we do a FISH, we do a chromosomal microarray. The diagnosis is made at 21 weeks. By 23 weeks, you have your result, and then you run exome sequencing. The patient's 26 weeks of gestation before you get a result of potential monogenic disorder. Well, you need to have an infrastructure, number one, to support the counselling that goes around that. The second point is, in a sense, of exome sequencing in terms of these variants of uncertain significance is in a sense opening a can of worms, and in a sense to be able to provide us, not just by getting a right diagnosis, in a sense it's about having an infrastructure to interpret many of these monogenic disorders that are picked up on, and for us this is becoming a real challenge. But I think the way the world is shifting, and maybe Dario, if you agree with me on this, in a sense, it points to the emphasis of first trimester diagnosis, because the way currently, and I think Australia is similar to many countries that are doing it, they're doing chromosomal microexome sequencing process. It's a third trimester diagnosis that you're coming up as a monogenic disorder. I think it points to the emphasis of first trimester diagnosis. Do you agree? Yeah. And in a sense of, in a first trimester diagnosis screening setting, I know we always come back to a debate of vaginal versus abdominal, but if you just want to comment maybe, Dario, on the importance of that and detection rates in terms of first trimester.
Well, of course it does, Simon. You're one of the, together with Rabi and everybody, key believers in the fact that you can screen for congenital heart disease in the first trimester. We publish also in that field, and I think nowadays, with unfortunately large exceptions of increased BMI, but you can carry out wonderful screening with the current top transducer, high-frequency transducer in the first trimester. So that's very relevant, because if you get a cardiac defects very early in pregnancy, then you have the option to carry out all genetics tests much earlier than you would do for later diagnosis. So that's quite important.
Yeah, thanks, Dario. Ravi,
I've got often a question: what do you do if you offer Invasia and the patient says she doesn't want to? Say, okay, so if you see nothing else, so good luck. You have only to write down, document that you told her that between 10-20% of the cases there may be monogenic disease, that she cannot come later on. That if I knew this. But if they don't want to do it, so why not? The opposite group is, they say, we ask them, why you don't want to know? We said, I will not change my decision. So if in that cases you find something more in this fetus, like let's say growth retardation, some brain abnormalities, and some cardiac anomalies, you tell them, in this case, the child will be operated within 2-3 days after birth. If we know by the definition the disease is going to be almost lethal or severe, you may decide after
an infrastructure. We have 6 genetic counsellors in the department. So if there's any question about anything, about a concern about anything, before we get into any of these discussions, you have a discussion with the patient and just get an understanding as to what direction they want to go with testing and what level of depth of testing. Fanur, I think there were some other questions that came in.
I think Asma has a question there.
Asma.
Oh, thank you very much. I have to say it's one of the best first sessions in a meeting that I had in 2024. So brilliant. Thank you so much. The issue of the association between brain abnormalities and heart abnormalities and genetic testing, for me, is quite relevant because we know that there is association of brain abnormalities and congenital heart defects, but we also know that the most of the old literature only did array. So in an era where likely that the exome will be the main line for genetic testing of babies with congenital heart defects, do you think that maybe a proportion of the brain abnormalities that reported in association with congenital heart defects were maybe undiagnosed genetic abnormalities? That's the first question. And the second question, and maybe just to remind Dario, a few years ago when we wrote the statement, and I think also Juleni was part of the team, when you wrote the statement about how to counsel the parents about the brain abnormalities. And I know that people were very cautious, particularly the cardiologist, about to tell or to state the association or the risk of brain abnormalities, and we only agreed for hypoplastic left heart. Should we be looking at the brain in detail? Because I work in the UK, and for isolated cardiac abnormalities, we cannot do exome. We only can do exome if there is associated abnormalities. Should we be doing detailed neurosonography, looking for brain abnormalities, for me at least to justify requesting exome?
I mean, I think when I put that question to Ravi, Asma, is what is today and what is the future? And I think the future will be, yes, I think exomes. And I absolutely agree with you 100%. We don't have the data, in a sense. We just have emerging data showing associations. But, we need 10 years of data before we can start saying, these are the figures, these are the chances, and these are what the implications are. Sorry, I interjected because that question was probably to you, Ravi, with regard to the brain.
Let's say, interestingly, I have to confess something. When I was preparing the book and I see cardiac abnormality, I was more involved in getting good images. But now the book is published. I'm not going to do this for the next 5 years. So when I see cardiac problem today, I will not exaggerate, but within 2 minutes, what is the group? And I will not spending, let's say, 20 minutes on looking to each detail, because I know this is the group, this is the cardiac anomaly. And then I will start working on the fetus, the whole head to toe. So I will go to the brain, I will look to the ears, I will look to the eyes, I will look to any sub details. I may perform some transvaginal scan because this is a heart anomaly. But I want to know, to tell the geneticist and myself, this is going to be an isolated. And I know that 10% of the cases will end up of being some monogenic disease. I don't want that 2 weeks later, they come and this is, let's say, this disease, and you start looking, it should have a hemivertebra. It is, let's say, cat-eye syndrome, and have you looked at the anus, and then you start looking at the anus, and you look at the ear tags. So I scan more accurately the extracardiac part in the meantime, because I don't need to have, let's say, the best tetralogy picture after the year 2024, because I have enough in my fundus. So, but I'm focusing then on the details, and I will do everything more.
I think it's, when we see a heart defect, the prompter there is to have a look at the rest of the baby, and there is the phrase that the most difficult defect to pick up is not the first one, but the second one.
Yeah.
And I think our genetic talk has shown the high association with chromosomal and genetic problems, but other papers, including one from our centre, has also shown a very high association with other structural abnormalities. So absolutely, and the brain being one of those key organs. So I think we should immediately have a very detailed look at the rest of the baby.
If I can add, because yes, of course, these fetuses with the congenital heart defects should undergo neurosono and is in the list of neurosono. Of course, for looking at major brain abnormalities, not for looking at delayed sulcation and gyration in these fetuses, because that's a challenging point, and it's today irrelevant and not clear whether this contributes to the higher rate of neurodevelopmental delay in certain congenital heart defects. So that's still a field of debate, whereas we should go for a transvaginal neurosono in fetuses with congenital heart disease as part of a total body check for these fetuses. One point I would raise, I'm not sure whether you in your countries there is the same issue, but what we encounter, because I'm 100% in line with what Rabbi is saying, there is no discussing the fact that in 2 days from now we will go for exome sequencing also for single subtle genetic fetal abnormalities. I had recently a case, it was pick up also GGF array, but it was a microdeletion that had only a cleft lip, not even cleft lip and palate. So, but still, I think that we'll go for exome sequencing also for single anomalies. The real issue that we are encountering in Italy is that we have a strong skepticism from the geneticist point of view, meaning that they are quite conservative in willing to launch themselves into diagnosing and counseling conditions, monogenic disorders in fetuses, because as you know, exome sequencing is heavily relying on the phenotype. Because if you enter the phenotype, the more dilated is the phenotype, closer is the definition of the abnormality. And of course, in the fetus, we have only a partial view of all the possible subtle genetic abnormalities that they may have on hands and face and so on. So in Italy, the geneticists are no, let's not do, or if we do only as a third tier and only in selected anomalies. So there's this gap between us asking for exome sequencing virtually in all cases of anomalies and then trying to.
Yeah. Juleni, yeah.
Thank you very much, everyone. I'd just like to put a different perspective to what we're discussing here. To a very high-profile audience, but we have 700 people. I'm not quite sure where they're coming from probably from a lot of places. So I think given that 10% there will be a monogenic problem, 90% will not.
Yeah.
So if you are in a country where, like in the UK, unless you find something else on the scan, you cannot offer its own. If you're in a country where it just financially you can't, what's the point of telling the family that, yes, this is a tetralogy, you look very careful, scanning, improve your scanning ability. What's the point of telling them that 10% of these will have a monogenic disorder if you can't offer anything else? Yep. When, from the cardiologist's point of view, we know that if we have a good fetal medicine assessment, yes, there is a risk, but is a small risk in the 90%. So are you going to worry these families that really want that baby, that for the child, for example, you can get good results for surgery? So how do you counsel the families? Do you then break in all of these genetic improvements to that family that you can't do anything about it? Yeah. For 10%, when 90% will not have a problem?
I think it's a very grounding point that you make, Juleni, and I think because we need to fit in case studies on the program and bite 5 minutes into the break time, but at the end of the day, it is a new technology, and I said, in a sense, I agree with you. We need to embrace new technology in a common sense point of view, and in a sense of what the health services around you that can support, because even in the health services that can support it, like Australia, I have to say that I think we're in deep water, because we're dealing with all the variations that we see and finding up incidental genetic syndromes, which you, in a sense, completely unrelated to the cardiac investigation that you started in the first place. But that's not to say we shouldn't move forward. We will meet again in the next number of years, and we'll have hopefully a clearer picture. So I
have a question, from one of our online participants, Rosina Severi. Do you try to show the origin of the neck vessels from the aortic arch view in every routine scan?
No, I just need to understand in a sense that there's the ISOUG screening examination, then there's the fetal echocardiogram. So we don't routinely image the aortic arches as part of a screening examination, not even just looking for the branches of the aortic arch or the ductal arch for that matter. It's only in the setting that when an abnormality is found, such for example on 3-vessel tracheal view, that you would end up to extend to look at the aortic arches. Yeah, great. Thanks, Fanula. So just